Welcome to today's webinar. My name is Russ Rowland, and I'm the Director of Marketing for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we'll try to get them answered during the webinar. Now I'll introduce tonight's presenter, Dr. Thayer Alqadoumi. Dr. Alqadoumi graduated from the University of Jordan in 2012, where he earned his first DDS degree. Dr. Alqadoumi continued his dental education in the United States, where he attended Loma Linda University in California. In 2016, he received his second DDS degree and continued his postgraduate training at Loma Linda University, where he received his MS degree in periodontics and implant surgery. Dr. Alqadoumi is an assistant professor at Loma Linda University in the Advanced Periodontics and Implant Surgery Clinics. He is also a member of the American Academy of Periodontology and the the Academy of Osseointegration, where just this last weekend he achieved his diplomate status in the Academy of Osseointegration. He's also a member of the California Society of Periodontists, American Dental Association, California Dental Association, and the AAID, as well as the Western Society of Periodontics. Outside of dentistry, Dr. Alqadoumi enjoys watching sports, playing soccer, traveling, and spending time with his family. We appreciate you, Dr. Alqadoumi, spending time with us tonight. It's always a pleasure. We look forward to the presentation, and I'm sure it will be impressive as always. I'll turn it over to you.
Thank you. Thank you very much, Russ and Osteogenics, and everyone for having me with you to spend this evening to talk about the socket preservation and where we want to take it from easy cases to more challenging ones. There's only one thing. Shelly from Osteogenics, she's a good friend, and I want to make sure that I keep her happy. I forgot to add this to my slides. I hope everybody can see it. I go also by the Lord of the Gums, just to make sure that everybody's aware of that. And I want to thank Osteogenics also for all their attention and mails I get from them. It says the Lord of the Gums. So thank you. I hope Shelly's happy now. So when we go to the topic of alveolar ridge preservation, we know by no doubt now we have a lot of studies. And I want to today touch a little bit on those, on the importance of the alveolar ridge preservation and what happens from a biological point of view when we extract a tooth. And basically what we have two phases. In the first phase, we extract the tooth, we get a blood clot, then granulation tissue fills the socket, and then provisional matrix and move-in bone by 3 weeks. At this point, the bundled bone is completely resorbed, and it causes a lot of vertical reduction in the ridge height. The second phase, where we get more buccal and palatal bone resorption in a horizontal manner by 15 weeks, and we get mostly horizontal ridge reduction with slight vertical reduction. And when we do socket preservation or alveolar ridge preservation, what we're trying to do, we are trying to attack mostly the second phase, which is the horizontal phase, and a little bit on the vertical aspect. So no matter what we do, we will get some bone remodeling, but we're trying to reduce it as much as possible. And when we look at this important study by Araujo, this is a really landmark and most cited study in the field of periodontology, where it talks about all what I explained to you about the phases and the remodeling and the bundle bone, which lines the alveolar socket and goes all the way to the crest of the buccal bone. And this is the one that makes most of the damage that we get after tooth extraction. So what do we have studies when they look at what happens post-extraction from a bone reduction or bone resorption point of view? In this study, we see that we have, in the systematic review, we have about 29 to 63% reduction in the horizontal bone width and about 11 to 22% in the vertical, and that's 6 months after tooth extraction. What about when we look at this important study by Schrupp and others, where they did a clinical and radiographic 12-month study, and they wanted to look at the bone healing after tooth extraction and evaluate it. What did they found? What they found that we have 50% reduction of the width happening at 12 months. And the sample size was mostly premolar and molar area. And what do we know in general when we talk about molar and posterior area? Generally speaking, we should have a thicker buccal wall when we compare it to the premaxilla. And two-thirds of that bone loss happened in the first 3 months. So what happens in the anterior maxilla? When we look at all the studies, like for example from Danny Boozer group and Chapuis, they looked at in general we have less than zero point 0.8 millimeter buccal wall thickness in the anterior area, in the premaxilla area. After 8 weeks, we get up to maybe 7 to 8 millimeter vertical bone loss with thin wall phenotype. So, how common do you see a thick wall phenotype in the premaxilla? Not very common. So, that's why alveolar ridge preservation is really, really important to manage these cases and reduce the amount of reduction that we get. Because otherwise, I may get cases like these. I may get cases with vertical and horizontal bone loss in the premaxilla, like this one. Patient lost their canine and lateral incisor. And now, in order, yes, we have the tools nowadays to fix such problems using the tie reinforced PTFE, but the patient has to go through a hectic procedure, spend a lot of money and time because we have to wait for the bone to heal to get a result that would look like this after 8 or 9 months. So we're able to regenerate these defects. But what if I can avoid that and reduce the chance and need for such procedures? So the first and the most important thing, know what kind of enemy we're dealing with. And when I look at the socket classification, we're going to go with alien classification, where this classification is based on two things. Where is the soft tissue and where is the bone? Just to make it easier for everyone to comprehend this. So type 1 is if the soft tissue margin and the bone, they are where they need to be in relation to your CEJ. The next one, type 2, is when you have the soft tissue where it needs to be, but we have deficiency or dehiscence on the bone on the buccal. This is definitely more challenging. And class 3 or type 3 is the worst, and that's the most challenging when we have a combination between hard and soft tissue problem. And I'll try to show you today a combination of both. I'm sorry, of all these cases, how to treat type 1, how to treat type 2, and how to treat type 3. Now, what do we want to do and what do we want to use? If you have attended previous webinars that I've done with Osteogenics, you'll get to see and watch more details and dig into alveolar bridge preservation techniques, why we do it. I threw in some literature today, but I didn't want to bore you. I wanted to focus more on clinical cases. But today I will focus on using the DPTFE, the dense polytetrafluoroethylene. And that membrane, the Cytoplast TXT200, can be either the PTFE alone, or we can add tie reinforcement, titanium, to it. And I'll show you when I use each case. But in general, what are the advantages? Why do I like this membrane? Why do I love it? Because I'm preserving the interdental papilla, I'm preserving the width of the keratinized tissue, and I'm getting less chances of infection and better bone quality at the end of my alveolar bridge preservation. And at the same time, to remove this membrane, it is a very simple procedure. It does not require anesthesia. It's exactly like if you're removing suture. And I do hear some doctors, they want less patient chair time, and they always have concerns with using a non-resorbable membrane. But guess what? For me, I want to see my patients at 1 week, and I want to see them at 4 weeks. All what it's going to take me 1 or 2 minutes out of my time. And this way, I'm comfortable, and I know that I've given my patients something to protect the bone graft material that I placed. And I'm comfortable that I will not only do that, but I will also avoid multiple surgeries later in the future by doing this technique. And when we go in, we remove the membrane about 4 to 6 weeks after we do the bridge preservation. Generally speaking, I remove it at 4 weeks. Some cases I leave it longer if I'm using the tie reinforcement and I have a buccal wall that is gone. But what you want to see is this is the presentation of the connective tissue that will look underneath it. we want to see a dense connective tissue, as this study showed us. It's a dense connective tissue with some mineralized matrix in it. And that scanning electron microscopy, what they did is also they looked at the membrane. They looked at what do we have on the surface that is facing the bone, and what do we have on the surface that's facing the oral cavity. And definitely the one that was facing the oral cavity was filled with bacteria, and the one was facing the bone was clean, no bacterial colonies on it. So that is telling us that this membrane is doing a nice protection and giving you a good coverage, maybe better than what Geico would give over that bone grafting. So I will trust this membrane over my bone graft. Now, when we look at other studies by a good friend, Dr. Eliane Barboza, when she did the study to compare the amount or the zone of keratinized tissue that we get when we use the dense PTFE compared to other extraction sites without primary closure. And when we look at those 15 cases, we found, or they found, that we have about 6.6 millimeter more keratinized tissue and about 1.4 in the cases that they did not use the dense PTFE membrane. So we're getting better and more keratinized tissue around the implant when we come later on to do our implant placement. And we all understand why we need keratinized tissue around implants. We all understand that sometimes we have to do soft tissue grafting after some GBR procedures in order to get tissue back. And in this study, they did that, which they wanted to compare the use of the cytoplast membrane, the TXC200, the dense PTFE, to the GBR with a buccal wall dehiscence cases. And they did an open healing with the dense PTFE, and they did a guided bone regeneration on the other cases. And what they found with the histomorphometric evaluation, that there was no statistical difference between both techniques. And they also found that the buccal plate, you were able to reconstruct it and get it even when you intentionally leave the membrane exposed. And I will show you a lot of cases today that will relate to that part. So let's start with cases. First, I'll start with you with a very simple, predictable case, but kind of show you what do you do in cases when the patient is not ready for implant, whether financially, whether mentally, whether whatever reason, or if you're not able to do immediate implant. Here in this case, this was calling me to do an immediate implant, but financially the patient was not ready. So what do? We place the bone graft, and we want to place the cytoplast membrane, the DPTFE. So I'm going to be referring during all lecture as cytoplast, just to make your life easier, instead of me going and say DPTFE. So I'll place the cytoplast membrane extended 3 to 4 millimeter away from the edge of the bone on the buccal and the lingual or the palatal surface. And then we will suture above it. So we place the bone graft, then we place the membrane, and we want to make sure it's not touching adjacent teeth. It is a non-resorbable membrane, so you have to trim it in order to avoid it touching the adjacent teeth. Now, if you see that you're extending way beyond the 3 to 4 millimeter on the buccal lingual aspects, still go ahead and trim that membrane so you're not getting too much excess down apical, so you decrease the chances of exposure later on. And we suture using our glycolon suture that I like usually to use. It maintains tensile strength up to 2 weeks. And it's really nice suture to handle and use. So look at the healing. Patient comes back, and I'm happy when I see it is clean and patient doing a good job, but also I'm happy if I see food and stuff that are nasty here because it was prevented from going down deep. Access denied. And after I remove the membrane, this is what I would like to see. A dense connective tissue underneath. Even if you see a little bit of bone particles, nothing to be worried about. Just rinse it out and let it heal. Let the body take care of it. Then we come back, we have nice soft tissue. We have nice bone. So it is a hard and soft tissue regeneration. And we place our implant where it needs to be. And we have good tissue, stable, 2 years out, things looking good from hard and soft tissue aspect. Now let's come to another case where this patient was going to lose both premolars due to obvious periodontal disease and endodontic involvement. And In these cases, when I have a buccal wall problem and deficiency and such amount of bone loss, I previously used to go for a primary closure in those cases. But nowadays, I can leave it with open healing, with the with the cytoplast membrane, and using the allograft FDBA and suture and open healing. So 3 months after, we have regenerated good bone on the buccal, which is looking good. We place our implants and we come back, and this is the day of the uncovery. Look at the amount of keratinized tissue that we have. I do not need to do any soft tissue grafting. And when I expose to look for my implants, I can't find them. That's a good problem. I'm happy to see that I have a nice turnover on the bone on the buccal, and we have regenerated good bone. And this is a year out. So when I compare where I started to where I ended, this is a challenging case. I have a neighboring implant and a neighboring molar that is partially compromised, that we're trying to leave this tooth as long as we can for this patient to give her some posterior support until it gives up on us. But generally speaking, this is great regeneration when you look at what the patient had to go through if we did not go with this way. Now, another case with a perioendo involvement and some external root resorption that was associated with this root. And after extracting the teeth, we have a buccal wall deficiency and dehiscence. But the good thing is that the interseptal bone is up high, and it will help me, give me that tenting of the cytoplast membrane. So in this case, I think this one I use, since it's a larger span, you can get the cytoplast, the TXT 200, not the singles, because the singles, you can use it for a single socket, whether a molar, premolar, or anterior, you can cut it and trim it. The cytoplast TXT 200, this is a larger size membrane where you can include it to the full area and just trim it as needed instead of using multiple membranes. And then we suture with the cytoplast sutures in this case. And this is the regeneration 3 months after. So usually in these cases, I wait 3 months. In previous webinars, I did discuss Brian Mealy studies about what if you go at 3 months, what if you go at 6 months. No significant difference in the amount of vital bone and residual graft. So by 3 months, you should be okay to go in, as long as you're using FDBA to go in and place your implants. So enough width, nicely regenerated buccal bone, and also soft tissue looks good. We place our implant and we let it heal to come back later to uncover. Now, what if I have a premolar with buccal wall deficiency all the way to the apex and adjacent tooth is an implant? And those are challenging cases that, as I mentioned previously, I used to go for a tension-free primary closure. But nowadays, I use titanium reinforced PTFE, the cytoplast, and we place the FDBA and we leave it with open healing. And if I look at how things looked at 10 days and 5 weeks since I had a buccal wall defect, as I mentioned, I like to leave it a little bit longer. That's when we remove the membrane. So you see a little bit of bone particles here. I'm not concerned about them. It will heal and it will take care of itself. So 4 months out, I'm looking about a really nice regenerated width, as you can see on the CBCT and on the buccal aspect. And 4 months soft tissue also looking good. So now in one step, I have avoided the need for major GBR and I have avoided the need for soft tissue grafting. And patient comes back, we see where the nicely regenerated bone, we place our implant, and 5 years out, things are looking stable. And here is a bite wing for 5 years follow-up, how hard tissue and peri-implant bone level looking good for this implant. Now, when we come to another case where we have a buccal and lingual defect that was associated with implant that we removed a failed implant. And as you can see right here, I'm not showing you how to release the flap, but what I'm trying to show you is that we do have a defect on the buccal and a defect on the lingual. And in this case, for some reason, I didn't feel comfortable since I had both defects, buccal and lingual, to leave it with open healing. And I wanted to go with a tension free primary closure. And when you already have an implant and a crown, you have a really wide socket, and getting a tension free primary closure makes it a little bit more challenging, and the chances of exposure goes up more. Even if you're a good surgeon, still the chances of exposure are there up to 25 to 30% of the time. But what is important, it's not why did the exposure happen. Yes, why it happened, it's very important. You need to look at all the factors. But also it's important is how do I manage it and how do I prevent that from happening again. So we stabilize the tie reinforced PTFE with the Mazepin tack system. I love this. A lot of people ask me, how do you tack from the lingual? Just go to the contralateral side, and this tack holds really nicely to the holder. It doesn't come off. So it is easier to manipulate. It is actually harder to remove the holder from the tack because it really stabilizes it really nicely. So we place one tack on the lingual and one tack on the buccal, and we go for a tension-free primary closure. But lucky me, I love when I have complications. And that's how we learn, and that's how we know what can I do when things happen like this case. So I leave it a little bit longer, and I bring the patient back at 5 weeks. And as you can see here, I pulled on the titanium reinforced PTFE membrane that I have, no anesthesia. You can use topical if you want. And one tack came off, as you can see, and the other one stayed inside. And I'll show you a video in a bit how to do that. This is Teflon. You can pull on it and rip it through that tack that you have placed. And when I come back to place the implant, I can take that tack out. And if that tack has stayed in there and it's nice and solid, I'll leave it. I don't have to take it out unless I have a thin phenotype and I can see it through the buccal or the lingual. So this is what I have after I remove it. This is a beautiful, nice sightseeing that I would like to see when I remove my membrane for such case. I have a dense connective tissue that I know it is letting my bone to cook underneath. And when I come back and take CBCT, I have maybe around 10 millimeter width and 19 millimeter vertical height. And we have regenerated this case. When I look at it, look at the soft tissue. That exposure was in my favor because now I do not need to do soft tissue grafting. If I left it to the first GBR intention that I did and go for a primary closure, I may would have needed to do some soft tissue management. But now with that exposure, it did fix it on its own. And look at the bone that we have regenerated. And we place our implant, let it heal. And when I compare before and after, this is a really nice way to regenerate this bone, just using this technique from before to after and avoiding larger and more advanced surgery. And this is how the case was finally sent to the restorative dentist for the final crown. Let's go get to more complicated cases. So this tooth, this first molar, number 14, needed to be extracted. Severe bone loss, and you can see no buccal wall. And when I look at all these views, this is a nightmare when we want to treat it. And this is how the picture is looking clinically. And I do have a buccal bone loss and palatal bone loss. And those cases are not easy. Usually I would let it heal, come back 6 weeks after, do a full-blown vertical GBR, and wait 6 to 8 months or 9 months, and then come back, place the implant, and do some soft tissue grafting. A lot of things that we had to go through. But now I've been working on this single tack technique that I call it, and I'm documenting some cases to publish that. But what we're doing is we're using tie reinforced PTFE, the cytoplast, and I'm placing one tack on the buccal. Now, if you do have the 12 by 30 length, it can go all the way to the palatal. If you can't, you can add another membrane over it to help advance it to the palatal side and fill any gaps that you may have when you place your membrane. So for example, in this case, I used the amnion chorion membrane, and as you can see, it extends over the sides of the PTFE and goes to the palatal side, and then I leave it with open healing. I'm using my cytoplast sutures. And as you can see, we did one vertical incision in order for me to get access to be able to clean. There are some other cases that I'm documenting. Sometimes if I see a buccal defect that I'm able to contain and clean through the socket and I still want to tack, I place one vertical incision like a vestibular incision and just tack it through that area instead of me raising a flap. So that's another way you can do it to avoid flapping these areas. So 10 weeks after, actually this is immediate post-op. So after we finished, had the patient take a CBCT to see what did we do and how much we regenerated. And I wanted to see how stable is that over time. So pre-op to immediate post-op to 10 weeks, about a millimeter or two reduction of the height and the width we have got, which I will take that. And also this view, we can see we've done quite a bit of good regeneration when we consider this case from where we started to where we ended. And when I look at it clinically, soft tissue, even though this patient had low exposure on the palatal side, and you can see that, still with the complication, we were able to get good bone width and height to place implant. And as you can see in this video, I love it when I see blood, because that tells me this bone is nice and vital. And look at the buccal wall, considering where we started. This is a really difficult and challenging cases because it's not only buccal, but it also has a palatal component. And I was trying as much as possible to get more light. I need to get another camera, but I have to have my own office first to get better lighting. But you can see that I have, as we zoom in now, we have regenerated nice bone on the buccal and the palatal considering where we started with just one technique and waiting 3 months. Now, I went in 3 months for one reason, wanted to see how things going to look at 3 months. I had good stability, good insertion torque for my implant. I would want to say wait maybe 4 or 5 months just to give it more time to mature, but definitely more studies will be needed to tell the difference. But when I remove the membrane, this is the tight reinforced PTFE. I flick it out as I showed you with the periodontal probe, or you can use a exploder. And then with the cotton plier, you try to pull on it. The patient is not numb, no anesthesia. I did not even use topical. Those high demanding patients, you can definitely use anesthesia if you want, but you don't have to. The first thing I would use is going to be a topical benzocaine. That's the first thing that I would use, okay? So we keep trying to pull on it. And if it doesn't come out, then you will try, here comes out the titanium. It dislodges out of the membrane. And then you can grab a hemostat that will put more pressure on it and that you're able to pull more on it to get it from the outside. The reason why I showed you this case, because this is the one that gave me a hard time. I did not crop it. I did not cut anything. I wanted to show you what I had to go through as I was doing it to try to remove the membrane, because I want to show you reality. Some cases when you tack, it comes out easy. Some cases, like this one, you have to go multiple times before you're able to pull it completely, okay? And we'll leave the tack in, and when the time comes, we will remove it. So looking at another case, and I really love this case because this is from my first year in residency. And this is when I did not know much, and I wanted to do a extraction of these premolar teeth and do the bone grafting at the same time. And you can appreciate the defect here, and using the titanium reinforced PTFE. And as you can see, stabilize it with tack on the buccal and place the bone grafting and sutured it. So you can tell this is a suturing of a first year resident that at that time I was a little bit ignorant about how to do it really well. But guess what? This was a really good learning case that I learned a lot from, that we had exposure at 3 weeks. And at that time, I haven't seen or heard of other people. What would they do with tie reinforced in such case with GBR, do I flap it, open it completely? Do I curette the bone? What do I do? So I decided to treat it as a socket where I pulled the membrane, same way, no anesthesia. I just pulled the membrane, removed the sutures, and this is what I can see at 4 weeks. Dense connective tissue underneath. Let it heal 6 weeks, 2 months, maturing more, and then comes back 5 months, and we have regenerated good bone. Did we lose some on the vertical aspect? Yeah, maybe we will lose some because we had exposure. But did it prevent us from do our implant planning and place our implants? No. And that's the case that made me starting to use the tie reinforced PTFE in an open healing concept when applicable. Now, you have to understand some cases with smoking, with diabetes. If they're uncontrolled, usually we want them to be controlled, but sometimes you do with emergency extraction. You may get more chances of problems, but you put them in antibiotics, you keep an eye, and you deal with those cases as you go. And as you can see, we ended up with good soft tissue, good bone, and final prosthesis done by a good friend, Dr. Alqadoumi. So another case where we have, I'm trying to show you a lot of cases. So I'll show you a variety of cases, complications, much more harder, less harder stuff, just to kind of get everybody to see what we go through day in, day out in private practice. So this one, as a periodontist, I see somebody attempted to do a free gingival graft before, but we do have some recession, thin phenotype, and a soft tissue problem around that molar that need to be extracted for an external root resorption. And we have no buccal wall, as you can see in this case. So what do? Is we go to the palate, get some connective tissue graft. We tunnel and advance the graft using glycolon sutures here. And the first layer you can see of my connective tissue graft is acting like a wall for me, but I will still add my cytoplast singles on the buccal, and I place my FDBA, and I will suture over the membrane to contain the membrane and keep it in place using my glycolon sutures. So patient comes back, soft tissue, the first thing I look at, looks good, nice thick keratinized tissue, beautiful coverage, and at the same time width is good. We got some of the buccal wall back, but now we have a vertical deficiency to be able to place implant. So what did we do? And the ones who were at the AO, we discussed, we did a lot of lectures about this, but using the Versa, the osteodensification technique, I go in and I place my Nova bone. I take a X-ray to confirm that everything is looking good. And then I place my implant and we go for a tension-free primary closure. And later we come back to do the uncovery. So you can see multiple things were done at this case, from soft tissue grafting to alveolar ridge preservation, come back and do a crestal sinus lift and placing the implant. So it's always these are the cases that you have sometimes to deal with what you get through. Now, when I come to the last case, I'm trying to run quick so we're not behind on time, and I'll leave some time for questions. This is a nightmare where we have the central incisor with advanced periodontal disease and severe bone loss on the vertical and horizontal aspect, and soft tissue problem. So this is your type 3 alien classification. And when you look from the occlusal, I'm scared even more. And when I take out the tooth, how can we manage this case? Now, you can let it heal, come back 4 to 6 weeks after, do a full-blown GBR with tie mesh or tie reinforced PTFE, whatever you like to use, and then come back 8 months after, place your implant. Then at the uncovery, you may have to do some vestibuloplasty, some soft tissue management, and then get it ready for the next phase. But what can I do to fix this problem all at one time? Yes, it's not a simple surgery. It's not something that you can do Monday morning, but it is one thing out of your toolbox that you can use and apply to make the patient go through less surgery, to make the patient go through less expenses and less pain. I may have more pain at phase 1 compared if I've done anything else with phase 1 in other techniques, like to extract and let it heal. but on the long run, I will have less problems. So this is the defect that we have: slight vertical, but mostly horizontal. And what we did is we did a VIP connective tissue graft, a vascular interpositional connective tissue graft. And I'll show you a video in a bit where we tunnel that through the palatal surface. We do the single tack technique, one tack on the buccal, tie reinforced PTFE and the FDBA, and we flip the membrane to the palatal, and I bring the connective tissue graft over in the buccal, and you can see my beautiful purple suture, the glycolon suture over here, stabilizing my connective tissue graft to the periosteum. So now I have stabilized the membrane, I have stabilized the connective tissue graft, and I have blood supply coming for the connective tissue graft. Those are all, you're signing up for success. And then I close it up, and I do not have to go for tension-free primary closure. It is open. I still have the connective tissue graft exposed. And this is where we harvested the connective tissue graft from. Now, if I go back, let me show you also what I did. Right here, I did cornic suture in order to help me with stabilizing the oral mucosa to the periosteum underneath it, and it also helps me to avoid future soft tissue problem and loss of vestibular depth, and it will help me with verticalization of the flap. And I will show you, as things were healing, how it looked like. So this is immediately after we finished the extraction. And this is pre-op, this is immediate. And I will walk you in the next couple of minutes that I have through the surgery. So we do a one vertical releasing incision, and we clean the defect and we visualize what do we have, okay? And we remove any soft tissue tags, any granulation tissue, make sure that it's really nice and clean, and start working on the palatal to harvest the connective tissue graft. And this is a different harvesting technique because we are planning to keep the blood supply. And here I need to go full thickness in order to detach the connective tissue graft and flip it over to the buccal and create a little tunnel and get it underneath the tunnel. And if you want to watch all of these videos at the end, I'm working on my website. Hopefully sometime soon it will be out, so you'll be able to watch all of these. But this is basically kind of like a glimpse of what to expect. We're going full thickness. I'm using my elevator to elevate the graft off the bone. And we want to flip it after I release it and get it through a little tunnel that I will create so I can get more vertical tissue height. So you see that little tunnel? And that will keep the tissue more vertically placed for me in order to get even better soft tissue height at the end. We stabilize it on the buccal using the single tack technique, as I mentioned, with the master pin tack. Then we place our bone grafting. We flip the membrane and make sure it's not touching adjacent teeth. We put it under the thick palatal tissue and thick connective tissue graft. And with glycolon suture, it's a PGA PCL, I'm suturing to the periosteum. And here I want to thank my assistant. I think my camera that is over my head moved a little bit and it's not 100% clear, but you guys can blame my assistant for that. But you get the concept. We're stabilizing the connective tissue graft to the periosteum, and we close it afterwards. So this is how things are looking at 6 weeks. I have good vestibular depth, and I have nice tissue width and tissue height too. Considering where I started, I will take this all day long. And from before to after, and this is something that I would love to have with my cases if I'm able to achieve it with one single case for the use of the tie reinforced PTFE. With that being said, I want to thank everyone. I tried to leave some time for questions. Feel free to reach out to me, whether by email or social media, whatever you like, and I'm more than happy to answer any questions that you may have.
Thank you, Dr. Alqadoumi. Great presentation as always, and really appreciate your time. Appreciate you sharing with us. We do have a few questions here, with more coming in. So I'll go ahead and start with the first one that came in. When you're using the titanium, we get this question a lot, so it's a great question. When you're using the titanium reinforced dense PTFE for socket preservation, with a buckle wall defect, do you still remove it at the 4 to 6 week time frame? I know with the non-titanium reinforced membrane, the company's recommendation is that remove it 3 to 4 weeks. Whenever you're talking about incorporating the titanium reinforced membrane and throw in to the equation that you have a buckle wall defect, how does that change the situation as far as how you choose to follow up and when to remove the membrane?
Perfect. Perfect. Great question. So the cases that you've seen with the buccal wall defect, all of these cases, the membrane was removed between 5 to 6 weeks. The reason why I don't leave it longer is that PTFE, the tissue will try to. The reason why we get more keratinized tissue is that the tissue will try to get away and open up from that PTFE, and that's how we get more keratinized tissue. So more apical migration will happen over time if you leave, especially with thin phenotype, if you leave the PTFE membrane in. So my recommendation is to remove them. 5 weeks is a happy medium. 5 to 6 weeks with when you have a buccal wall defect. Otherwise, I remove them at 4 weeks if they do
Okay,
not have a buccal wall defect.
understood.
And the
Um,
cases, the videos you've seen, all of these were removed at 5 to 6 weeks. So we're still able to get good bone turnover and regeneration on the buccal.
Understood. Um, I know a topic near and dear to your heart here. Do you ever add an amnion chorion membrane between the graft and cytoplast membrane?
Not all the time. It depends on the case. So you've seen most of my cases, I didn't need to because I was able to, it was a, let's say, a smaller defect that you can contain, or I was able to get the membrane all the way to the palatal side. Now, when I'm not able to get to the palatal side, or I have a defect that is so wide, mesiodistal, and I feel that I need better containment of the graft over the edges, then I may add the amnion chorion membrane. I get the biologics that I get out of the membrane, and it's thin membrane, so I'm not adding so many factors when you compare it to like to using another collagen membrane. You can definitely use collagen membrane, but I use the amnicorin for the growth factors aspect of that. But not all the time, only when I see there is a need. There is no recipe. Everybody has to understand there is no recipe how to treat things. It's just what you go in and you see the defect and you see what you're dealing with. If I see that my membrane is stable, it's adapting nicely to the bone. If the defect shape is more of a V shape, then the cytoplast will be more than enough. I do not have to use any amnion chorion membrane. If it's more of a W shape, look at Jocan study. This is a much harder defect, and it might involve some of the adjacent teeth. So I can't have my non-resorbable membrane touching the adjacent teeth. That's when I get the amnion chorion membrane to help and have a part in the game.
Gotcha. Um, it's a good question. In general, in your experience, is a bone graft outcome better when the cytoplast dense PTFE membrane is completely covered versus when it's left exposed?
Very beautiful question. Now, generally speaking, I would say yes and no. Yes, there are cases that I've seen that the outcome is better when we are going for a tension-free primary closure for sure. Now, I have other cases that I went in and I left it exposed and I went in and I swear it was like drilling in D1 bone. It was really, really dense. But as a general rule, I think we can. all agree that if you go for tension-free primary closure, you're protecting everything underneath better than if you have it open. But if I leave it open and I avoid the damage that a tension-free primary closure will cause me, and I'm able to regenerate, and I'm able still to get good bone maturation and place my implant, and over time that bone will still turn over and it will improve. That's why you will see me never place an implant for myself and put a healing abutment. I will place my implant and I'll go again for tension free primary closure because I want to allow that bone to heal more. I want that bone to mature more. And then if I need to come back at the uncovery, do any technique like a roll flap or more palatal incision or whatever, I can do it at the time of the uncovery and I'm giving the time more bone.
Gotcha. To that point, got a couple questions here that I think you can answer at the same time. Um, do you utilize GBR simultaneously with implant placement and kind of in that same realm? Uh, why do you submerge your implants?
Great. Now, do I do GBR with implant? Yes. It depends on the cases, but generally speaking, a well contained defect within the bony housing, I do GBR at the same time as the implant. A vertical GBR, I do not do it at the same time of implant because I want one vertical at a time. Yes, I've seen from Ramon Gomez Meda great cases with vertical GBR. But for myself, if it's horizontal, I have higher and better predictability and it's contained, yeah, yes, then I'll go with it. Why do I go? And I think I answered that question for why do I cover, submerge my implants? Because I want to give more time for the bone to heal and then come back later and manage the soft tissue. And I mean, I'm sorry to say that. I don't trust anyone. I don't trust my patients. I don't trust myself. I'm a bad patient. I had my tooth extracted. I went home same day. Even before anesthesia wore off, I started eating until I noticed that I'm swallowing blood, and I was chewing my cheek. And I know better, right? So what do our patients do when they go home? They will chew on that healing abutment. I want to avoid all of that. I take it easy. I will come back later, do uncovery. It's much predictable that way.
Um, do you have evidence that shows better bone or soft tissue healing with PTFE compared to other resorbable membranes?
Now, me personally, my studies, no, but studies are out there comparing the PTFE to other collagen membranes, to no membrane, the amount of keratinized tissue you get. Now, better bone healing, I'm not aware if there is a study. I know there is a study from Texas about the use of the cytoplasm membrane and the FDBA, the Encore bone. It's a CBCT evaluation at the stability of the bone 4 months and 1 year, and they see no significant difference, and still the bone maintains a good width and height. But there's nothing on top of my head that compares both and look at the quality of the bone in terms of the amount of residual bone, vital bone, and all of that.
Yeah, I would just add to that I'm not aware of any that they might be out there, but you know, there's also a study out of that same group that you mentioned that compares the use of a mineralized demineralized mixture of bone compared to a 100% mineralized bone graft,
Yeah.
but all other things are the same. So in other words, both are grafted with dense PTFE membranes. So it doesn't address the question that the clinician asked. It's a good
And
question.
this is a great question. I always thought in my mind, what what would happen when I have an open healing and I have dense PTFE or I have collagen, and both exposed to the oral enzymes, and we know what the oral enzymes will do with the collagen membrane when it gets exposed and what it will do to the dense PTFE. So if whoever asked the question is a resident, that's a great research project. Here we go. If any of our residents at Loma Linda is listening, this is another topic for you, but definitely a great question. And I think Osteogenics Symposium coming up. We have a lot of great lecturers coming to talk about these topics, which they dig into details about everything related to that question.
In your experience, it's a great question. It's kind of along these lines here, but talk a little bit about mineralized or demineralized bone in these cases. What do you prefer? Do you have experience with one versus the other? Do you mix them? When it comes to the allograft material that so many people use,
Sure.
what's your general kind of thought process on how to choose the correct material?
So, what I can tell you for myself, I use a mineralized cortical cancellous mix, um, 70/30. But generally speaking, the demineralized, we know from research that it has been treated to expose the BMP layer to give us more osteoinductivity in the um, in the bone graft mixture. But when I'm doing, let's assume GBR, I'm always adding autogenous bone chips. I harvest some autogenous, and I add sometimes, especially with advanced cases, some growth factors like RHPDGF. So that helps me with that aspect. But to answer it, it's cortical cancellous 70/30 mineralized. That's generally what I use.
Great. We have time for a few more questions, but we are not going to get to all of them. Unfortunately, there's a ton coming in. They're great questions. Um, uh, this one's good. If you have a case, and I assume the clinician's asking, it's a case where you chose to um, uh, try to achieve primary closure for whatever reason. It's likely a not just a simple extraction site case, and you're using a titanium reinforced membrane, trying to get a little vertical height or maybe some horizontal width. But it's a case where definitely leaving it exposed was not appropriate, and so you
Mhm.
achieve primary closure. Have you ever experienced the membrane becoming exposed? You know, in the healing process, and if that happens, how do you handle it? And is the bone graft lost or partially lost in these cases?
So maybe one time we should do a managing complication of the dense PTFE tie reinforced exposure, because I've got a lot of cases and I show how to manage. But I showed you one today. The one with the implant, after we removed the implant, was buccal and lingual wall defect, number 19. So that is exactly what we did. I went for a tension-free primary closure with the tie reinforced PTFE, and I had exposure at 3 weeks. So what did I do? I waited for 5 weeks. Then patient came in. I was not happy because I started to see more lingual exposure. That's when I see we're about to get to the edge of the membrane. That's when I have to remove the membrane. And I just pulled it exactly like as a socket. Other cases, to answer the question in a different way, with a I'm just doing a full-blown GBR, a healed site, vertical and horizontal problem, not at the time of extraction, not at the time of removing implant, and I do it and I get exposure. There are many factors we have to look at. First, when did the exposure happen? Was it at 2 weeks? Was it at 4 weeks? Was it at 6 weeks? Or after? Now, if it happens so early, before 2 weeks, I'm concerned that's a toast. Most probably it's gone. If it happens after that, what I will try to do, I will try to baby it. I will see my patient once a week. I'll put them on antibiotics, especially if they are diabetic or if they are smokers. I will see them once a week, have them use chlorhexidine, give them a surgical brush to keep the area clean, and I will go in when I see things are getting worse, exposure getting bigger, and about to get to the edges of the membrane, or if I see pus in the area. Now, when I remove the membrane, even if I flap the area, I will remove it. I will irrigate. I will not debride the area. I will leave it, put a membrane, whether you want to use collagen, amnion, chorion. I will close it back and let the body take care of it. And come back a couple of months after. you will see you have retained quite a bit of your bone. Even if you have to place your implant and do another small GBR, but still, it's not going to be a complete toast that you would think.
A great explanation. I'll also tell the anybody listening that there's some good articles out there in their literature about handling
Yeah.
and classifying complications. Specifically, a group out of Italy, author last name is Fontana. There's two different articles
And I
that do a
think
good
there's,
job through that.
there's one Dr. Vroom from the Netherlands
Yes, Dr. Vroom is also very
that
yeah, it's great.
talks
Um,
about the
two,
class.
two more questions and then we'll wrap it up. What complications can you expect if you allow the membrane to touch adjacent teeth? That's something you definitely mentioned as a company. We something what we really harp on when we're talking about the usage of these membranes. We do not want the non-resorbable membranes to be touching adjacent teeth. What's the reason for that?
Yeah, generally speaking, non-resorbable membrane in general, whether we're doing a socket or a GBR, it will prevent the recreation of the soft tissue and getting the attachment back to the root surface. So you're going to get an exposed area and you'll have a problem. That's why we avoid that from happening. Now, even if you place it and you come back before you dismiss the patient and you see it is touching, you do not have to remove the membrane. What I would do, I would grab a 15C blade and just run along the mesial and the distal over that part that is touching the adjacent, and you just peel it off. It's very easy. Maybe one day I should do a video about it. I'll show you guys, but it's pretty simple and easy. You can cut it with the 15C blade.
Great. We'll end with this question because we get it a lot, and I think it's an easy one for you to answer because you do so many of these cases. But what are your home care instructions after graft placement with these membranes?
Sure. So, generally speaking, those instructions they apply to almost every single surgery. Okay, soft liquid diet for the first week, and if you have a problem to identify what soft is, anything the patient can cut with a plastic fork. So have them buy the cheap one and ask them if they can cut it, they can eat it. And usually avoid chew on the other side. No brushing for the first week. Patients who are interested in spending some more money, I have them buy the Stella Life, or we send them chlorhexidine mouthwash. No brushing, as I mentioned, on the area for the first week. After a week, I give them a surgical brush and I have them start brushing that area until I remove the membrane. So they keep using the soft bristles brush for 4 weeks after the extraction. And when I remove the membrane, they can go back to use their own toothbrush. Uh, Avoid exercising. If they're smokers, good luck to convince them to stop smoking for a couple of days. But it's better if they quit. But I think they know they may die from lung cancer. So maybe having a tooth problem is the last thing they're worried about. What else? So diet, exercising. This is generally speaking if we're only talking about socket with no sinus problems, with no other issues. And
Great.
if we are in the anterior area, I'm sorry, and you want to
Go
give the
ahead.
patient a temporary prosthesis, please, Essex retainer. No acrylic by any means. If you are the best prosthodontist on earth, even if you're my wife, she's really good, still, I do not want you to do acrylic partial. It will put pressure on the area. It will cause problems. It will cause bone loss.
Yeah, we talk about that a lot. Absolutely zero pressure on the area in these sites.
Yep.
We've seen them go from looking fantastic to complete disasters just with the slightest bit of pressure from the prosthesis. So
Yep.
uh, we'll close it there. Appreciate all the questions, and if we didn't get to your question, I apologize. It's great that we had so much interaction. I just want to let everybody know that we appreciate you joining the webinar. There's going to be a feedback survey that will be emailed to you shortly as soon as we log off here. Once you receive that survey, if you will fill it out and hit submit, then that will prompt us to send you your CE certificate. So be on the lookout for that survey. Once you fill it out, like I said, you will get your CE certificate. Once again, Thayer, my friend, I appreciate you doing this for us, and appreciate everybody that took the time out of their afternoon and evening to log in and join us. We will see you next time. Have a great Friday tomorrow. Bye.
Thank you for having me. Thank you.